Welcome to AETCM, the Emergency Medicine channel. Today's topic, geriatric trauma. While managing a geriatric patient in a trauma, we have to keep in mind the advancing age of the patient and pre-existing condition of the patient. Trauma being the fifth leading cause of mortality in elderly population. The increased mortality is mostly due to the failure of properly triaging the elderly people who are critically ill. Due to senile nature of the patient, the trauma that is normal for a young patient could be critical and life-threatening for an elderly patient. So, access to higher quality of health care in the industrialized region and enhance the quality of the life, that is our increase in active lifestyle among the elderly people is currently causing greater risk of serious injury, but as the economy of the patient depends on the economy and health of the patient, status of the patient older age group with lower income have more disability and die younger than the who having more economic background, like better economic background. Achieving the best outcome for geriatric trauma depend on the comprehensive multidisciplinary action focused on meticulous initial assessment, effective resuscitation and continuous care. So, effect of aging and impact on pre-existing condition. Aging is characterized by impaired adaptive and homeostasis mechanism that cause an increased susceptibility to stress of an injury. It is associated with decline in the aging is associated with decline in the cellular function, which leading to diminished organ performance, which in turn decrease the body's ability to adapt and maintain homeostasis, thereby heighten the vulnerability to injury related stress, a phenomenon referred to as reduced physiological reserve. This is the cause for, because of reduced physiological reserve, the body needs more time to heal from the trauma. So, if a elderly patient having these 5 P's, which include cirrhosis, coagulopathy, COPD, CAD, ischemic heart disease and diabetes mellitus. These people are more likely to die than those without PEs. So, the 5 PEs that influence the outcome of elderly people include cirrhosis, coagulopathies, COPD, ischemic heart disease and diabetic mellitus. So, this is the effect of a normal organ system, its functional change when patient become elderly and implication for the care. So, in cardiac system, as we grow old, there will be decrease in the function, decrease in sensitivity of heart muscles to catecholamines, decreased myocyte mass, atherosclerosis of the coronary vessels, increased afterload, fixed cardiac output and fixed heart rate. Mostly if the patient having already CAD and on beta blocker, there will be fixed heart rate. These will imply in our care the lack of classic response. Because of beta blocker, there will be fixed heart rate, fixed cardiac output. The classic response of hypovolemia, that include tachycardia and tachycardia won't be seen in this patient. And the risk of cardiac ischemia will be more, increased risk of dysarrhythmias and elevated baseline due to atherosclerotic changes. There will be elevated baseline blood pressure. So, in the pulmonary system, as we grow old, there will be thoracic kyphoscoliosis, decreased transverse thoracic diameter, decreased elastic recoiling, reduced functional reserve capacity, decreased gas exchange, decreased cuff reflex, decreased mucociliary function, increased oropharyngeal colonization. All these can make the elderly increased risk of respiratory failure, increased risk of pneumonias and poor tolerance to rib fracture. If rib fracture is there, there will be decreased transverse thoracic changes, there will be increased chance of stagnation of collection that can cause pneumonia. Example, the cause of pneumonia in rib fractures. Then renal failure, in renal system there will be loss of renal mass, decreased GFR and decreased sensitivity to ADH and aldosterone. This in turn, there will be routine renal labs will be normal, but that does not reflect, the routine labs will not be reflected the dysfunction in the renal system in elderly people. Drug dosage for renal insufficiency will be different. Decreased ability to concentrate urine. Urine flow may be normal in hypovolemia patients. So, and increased risk of acute kidney injury will be more in elderly people. In skin, soft tissue and musculoskeletal, as we grow old, there will be loss of lean body mass, there will be osteoporotic changes in our body, change in joints and cartilages, degenerative changes, especially including in the C-spine area, loss of skin elasticity and subcutaneous fat, which causes in elderly, there will be, due to all these changes, can cause increased risk of fractures, decreased mobility, difficulty in oral intubation, risk of skin injury due to immobilization, increased risk of hypothermia will be there, and challenges in rehabilitation will be more due to changes, osteoporotic change and degenerative changes. In endocrine system, there will be decreased production and response to thyronine and decreased DHEA. So, this causes occult hypothyroidism, relative hypocortisone state and increased risk of infection in this elderly people. So the concept of fragility in elderly people, fragility is characterized by diminished response to physiological stress due to low physiological reserve and multi-organ insufficiency. This is in 11th edition of our new ATLS, they added this trauma specific fragility index, which enables the healthcare clinician to identify patient at increased risk of poor outcome and increased resource needs. So research indicate that targeted interventions for this fragile geriatric patient can lead to improved outcome. Basically there is a trauma specific fragility index. This is the index. We will fragility index. So we will calculate this index and we will individualize the need of the patient, and by individualizing the care there will be better outcome in case of trauma in elderly patient. So now we will talk about mechanism of trauma. Most of the elderly patient, as we increase old, there will be imbalance, and patient most common mechanism of injury will be fall. More common non-fatal, it could be fatal and non-fatal. Non-fatal falls are more common in women, and injury also fractures are also more common in females due to increased risk of osteoporosis. Fall can also is one of the main cause of traumatic brain injury in elderly. The risk factors for fall is advanced age, physical impairment, history of recurrent fall, medication use such as alpha blocker which can cause postural hypotension, dementia, unsteady gait and visual, cognitive and neurological impairments. Fall can also be result of occult infection or syncope, or even myocardial infarction can cause fall, syncopal episodes. Environmental factors like loose drugs, poor lighting, slippery uneven surface can also add to fall risk. So fall lead to trauma. Trauma can be fractures, especially hip fracture, which will reduce the independency in elderly patient. There will be morbidity is more in elderly people than mortality. So even a ground level minor nature fall can also cause life-threatening serious condition in elderly due to frailty, osteoporosis, existing chronic condition or underlying medication such as anticoagulant or antiplatelets. Next is motor vehicle crashes. This most of the time, if elderly people is involved in a motor vehicle crash, it will be in daytime, and it will be mostly in the weekend times and most commonly involve the other vehicles. So the contributing factors, most important contributing factor is low reaction time, greater blind spot, limited cervical mobility, decreased hearing and cognitive impairment. Additional medical condition like MI, stroke or dysarrhythmia can also cause a sudden syncope or sudden disturbance in an elderly's body, and that can also lead to MI. So if a elderly patient came with a RTA, we have to take an ECG or any other necessity thing to rule out any underlying stroke, MI or dysarrhythmia in addition to treating the RTA type collision injuries. Elderly people are also higher risk of fractures including the upper cervical spine and ribs due to osteoporosis. The traumatic brain injury also is one of the complications if he is on anticoagulant drugs. So next is burns. Burns mortality associated with small to moderate size burns in elderly is high due to if in a structural burn, in case of a building getting in a fire, due to slow reaction time and impaired hearing or vision, inability to escape, they have more risk of it's a high risk population. Then incidence and a spillage of hot water in the skin, even if if it's a superficial burn, younger individuals due to higher density of air follicles have aided to re-epithelialization than older people. Like they heal fast in younger people than older, and secondary infections are also common in older people than younger people in case of burns. Next is penetrating injury. Most common cause of injury in elderly will be blunt injury. Penetrating injury can occur, which can also cause one of the reason of traumatic death, most commonly associated with gunshot or self-harm or suicide. Gunshot could be self-harm or suicide. So damage from penetrating injury determines the initial mortality risk. For elder adults who survive the initial injury, chronic comorbidities and baseline frailty it determines the patient's return to independence and the morbidity and morbidity state of the patient. So this elder abuse is something that is newly added in ATLS 11th edition. So elder abuse according to CDC is defined as an intentional act or failure to act that cause or risk harm to an older adult, typically by someone they trust. This is manifestation include but are not limited to physical restraint. It could be emotional distress, neglect by the caretaker, abandonment, sexual abuse or financial exploitation. So it's our responsibility as a healthcare professional to remain alert. Since it could be varied presentation of elder abuse there, it can be either subtle manifestation from physical injury to less apparent signs like poor hygiene or dehydration. These are it could be an indicator of neglect. So elder abuse increases the mortality rate in older injured people. Abused older adults have 3 times more risk of having 3 times the mortality risk than non-abused. So the risk factors related to proprietors are history of mental health problem or substance abuse, history of medical problems, experience of traumatic life event, high risk, high level of stress, not prepared to take care of an elder, poor coping skills, experience of witnessing abuse as a child, social isolation, financial emotional dependency on a elder. In a skilled nursing facility, if the patient is from a skilled, we have to the risk factor include inadequate number of qualified staff and burnout among the staff. These are the risk factors among abusers. In the signs of elder abuse include stop taking part in activity that he or she usually enjoys, looks messy with uncleaned hair or dirty clothes, have trouble sleeping, lose weight for no reason, withdraw or act agitated or violent, display signs of emotional trauma like rocking back and forth, then unexplained bruise, burns, cuts, scars, broken glasses or frame, physical signs of punishment or being restrained, developing bed sores or avoidable conditions, lacks medical aids like glasses, walkers, dentures, and eviction notice for unpaid tax notices. These are mostly seen in US condition where eviction notice will be for mortgages and unpaid mortgages. They show the financial dependency of the abuser on the victim. So this exsanguinity, sanguinating external hemorrhage, which is management of uncontrolled external hemorrhage from laceration of or open wound will be by applying pressure, packing or lack of placement of tourniquet. While removing a dressing from an elderly patient, we have to take care due to the fragility, due to the soft skin. There's a chance of increasing the tearing and laceration by just removing the wound. Additionally, the hematoma and contusion have potential to expand and contribute to significant blood loss in case of elderly population due to diminishing elasticity of the tissue. Then also the use of other anticoagulants and antiplatelets in elderly population. So in case of primary survey, we with airway, this is as an ER physician, there are some necessity step we have to take care or we have to look for whenever an elderly patient came to us in any kind of trauma or any situation. First, airway. Primary survey, in primary survey as in a trauma, then older people have loss of protective airway reflexes, so it's on us to establish, it's a timely decision making for establishing the definitive airway. It's on us, it could be a life saving procedure to establish a definitive airway. Since there is loss of protective airway reflexes, increased chance of aspiration. So timely decision is very important to establish definitive airway. Then patient may have dentatures which can block the airway. So in case of airway, we have to look for any dentatures or whether they are obstructing the airway. Then in case of if the patient is edungulous, intubation will be easier. If the patient doesn't have any teeth, intubation will be easier, but bag and mask will be difficult. It will be a difficult bag and mask, and due to atherosclerotic changes, mouth opening and cervical spine management will be difficult. So for us, bag and mask will be difficult, and we have to look for mouth opening, and spinal management will be difficult. And while we should also reduce the dosages of drugs that is used for intubation. Since there will be increased risk of to minimize, reduce the dosage to minimize cardiovascular depression. So these are the physiological changes and the management we have to take care in case of elderly trauma. So in case of atherosclerotic physiological changes as we grow old, in airway atherosclerotic changes of mouth and cervical spine, macroglossia and decreased protective reflexes. Management include edentulous and proper sized laryngoscope and tube, and we can attach gauze in gums and cheeks to achieve a seal so that we can use the bag and mask properly, and proper dosage of intubation drugs. In case of breathing, there will be increased skyphoscoliosis, decreased functional residual capacity, decreased gas exchange, decreased cough reflex, decreased mucociliary clearance from airway. This by identifying, we have to early identification of respiratory failure and management of rib fracture and application of early application of mechanical ventilation. We can and early and proper application, we can manage these conditions. In circulation, there will be pre-existing cardiac condition or hypertension will be there, and classic response such as tachycardia to hypovolemia will be less, and likelihood of cardiac medication will be there. So we have to look for tissue hypoxia by looking at the CRF, capillary refill time, and we will administer balance resuscitation and blood transfusion early for obvious shocks, and use advanced monitoring systems like base deficit and lactate for timely assessment. Then look for the classic signs of hypovolemia. So in case of disability, there will be cerebral atrophy, degenerative spine disease, and presence of pre-existing neurological or psychiatric diseases. So liberal use of CT scan to identify brain and spine injury is ensured, with the ensure of early reversal of anticoagulants or antiplatelets can be done. In case of exposure, due to loss of subcutaneous fat, loss of skin elasticity, atherosclerotic skeletal changes and nutritional deficiency. We have to prevent hypothermia. Pad of brawny prominence should be padded to reduce the risk of bed sores, and also early evacuation and liberate patient from spine board and cervical collar to reduce the number of bed sores. So these are the things I already explained in that screen. In breathing, we have there will be decreased complaints of lungs and chest wall, which in turn increases the effort of breathing. Then physiology will be decreased by diminishing respiratory reserve. So elevated risk of respiratory failure is more in geriatric patient. So as aging, there will be suppressed heart rate and fixed cardiac output. So the response to hypovolemia and respiratory failure will be insidious, and decision to ensure the patient's airway and provide mechanical ventilation is fully appreciated, may be made before fully appreciating the underlying premorbid respiratory outcome. In case of circulation, there will be fixed heart rate and cardiac output. So the response to hypovolemia will involve increased systemic vascular resistance. So the systolic BP, that the threshold to identify hypotension. For a normal people, we will be like 160, is below 160 there will be hypotension, but for elderly people it is 110 mmHg. If it is over 60 years, the threshold for hypotension will be, because their baseline BP will be higher due to atherosclerotic changes in the arterial walls. So older age may not exhibit the typical compensatory tachycardia in response to hypovolemia due to factors like catecholamine insensitivity, atherosclerosis, myocyte fibrosis, and the use of beta blockers like in case of heart medication. This lead to reliance on increased systemic vascular resistance. Early identification of significant tissue hypoxia, hypoperfusion and is essential by using base deficit, serum lactate, shock index and tissue specific endpoints. So base deficits less than 6 or lactate more than or equal to 2.4 indicate occult hypovolemia. In case of shock index, it's greater than or equal to 0.7, have 83% specificity for indicating the need of transfusion in patients over 65. Resuscitation strategies with hypovolemia mirrors those of younger patient, emphasize the balanced resuscitation with blood products and fluids as needed. Circulatory failure in geriatric patient often suggests active bleeding. So early implication of advanced monitoring technique is recommended to navigate resuscitation effectively, especially considering the likelihood of underlying cardiovascular issue. Additionally, we have to, it is vital to consider the incidents like strokes, heart attack or dysrhythmia that could have precipitated the trauma. Disability wise, cerebral atrophy, in cerebral atrophy patient is more prominent to have subdural spaces. So the bridging veins are more fragile, and even for minor injury there is a huge chance of traumatic brain bleeds. In addition, there will be anticoagulant and antiplatelet medication. So elderly people are have increased vulnerability to traumatic brain injury, including intracranial bleeds. As atherosclerosis also play a major role in primary and secondary brain injuries. Due to moderate cerebral atrophy present in age group, the signs of intracranial injuries are immediately apparent on neurological examination. Prompt recognition and management of this condition include reversal of anticoagulant medication. It will improve the outcome in elderly patient. Degenerative diseases of spine places elderly people at the increased risk of fracture and spinal cord injury even with low kinetic ground level fall. Exposure, as I already told, due to lack of subcutaneous tissue and nutrition deficiency, chronic medical condition, they are increased risk of hypothermia. So, and rapid evaluation and early liberation from the spine board and collar can reduce the risk of bed sores in patient. Adjoint to assessment, we have to take X-rays of chest and pelvis to rule out any pneumothorax, hemothorax or fracture of pelvis. EFAS should be done to rule out any intra-abdominal fluid pneumothorax or pericardial effusion. In case of bullet wounds, foreign body series could be done in case of bullet injuries. Lab tests include complete blood count, coagulation panel, and hepatic LFT, RFT, toxicology in case of alcohol and desk screening can be done. Urine analysis for occult bleeding or potential infection. Thromboelastogram can be done if the patient is taking anticoagulants and there is evidence of active bleeding and which can help to guide the resuscitation. Have to get a ECG done to rule out any acute ischemia or arrhythmia. Echo can be done if there is cardiac dysfunction, and orogastric tube or urinary catheters can also be placed for feeding as well as for urine output monitoring. So after primary survey, we have to again have to close attention to the vitals of the patient, including comorbidities, medications and pre-injury level of functioning. We have to reassess the hematoma or laceration or bleeding site to look for any increase in bleeding. Since there is fragility of skin, there is increased chance of expansion of hematoma, and thorough secondary survey have to be done. In case of open fracture or complex laceration, we have to add an antibiotic and tetanus immunization updates should be asked for. And in adjuvants in CT scan should be done. Occult injuries are more common in older people, so the whole body CT scan can be useful in identifying injuries. Otherwise, we will be missed the injuries. It is important in patient with unreliable examination due to altered mental status from traumatic brain injuries, dementia, encephalopathies or intoxication, and also have to obtain plain X-rays if CT in case of fracture. So then frailty in 1/3 of older age are frail. So they determine the already told the traumatic index. By determining the index, we can critically determine the morbidity and mortality of elderly people. So this syndrome will decrease physiological reserve, increase vulnerability to stressors, result in diminished ability to withstand trauma, and higher likelihood of adverse outcome include prolonged hospitalization, increased need for institutional care and higher mortality rate. The older people, the geriatric people who are frail, are increased risk for deterioration, and it's mandatory to have a close observation of this patient. So goal of care should reflect the patient's wishes and be consistent with their values. Goal of care discussion should be take place when the patient is able, and advanced directive physician orders for life susceptibility treatment and out of hospital do not resuscitation order are very important among this population. So there are specific traumas that are common in elderly people. First one is rib fracture. There is increased risk of rib fracture as because of the anatomy of the chest wall. Chest wall will be more rigid as compared to younger people. In older people there will be more rigid, and also osteoporotic changes. So the chance of rib fractures are more even from a ground level fall. The primary complication with a rib fracture is pneumonia, occur in susceptible lung parenchyma because of underlying pulmonary injury or inadequate ventilation from pain causing atelectasis. The primary objective of care of patient having rib fracture is pain control and adequate pulmonary hygiene. Pain control can include oral medication, IV medication, intradermal medication or regional anesthesia. Opioids should be used with caution because these people, older people, are increased risk of respiratory depression and delirium. Regional anesthesia with either epidural catheter, prevertebral catheter or USG guided nerve blocks more favorable for this group of people to diminish pain, and also in people with increased risk of delirium. Regional blocks are more favorable, and use of incentive spirometry is also recommended. Next is traumatic brain injury. Highest risk for traumatic brain injury associated morbidity and mortality is due to patient's inability to recover, and also underlying delirium, dementia, and depression. It is difficult for us to distinguish from a brain injury from already patient's baseline GCS. So, the liberal use of CT for recognition is important in elderly people, along with aggressive and early reversal of anticoagulant therapy using prothrombin, complex concentrate, plasma, or vitamin K. The note should be, we have the choice of reversal strategy should consider the urgency of situation, risk of thrombosis, and patient's comorbid condition. Reversal agents should include PCC, vitamin K, and we also carry the risk of thromboembolic event and can be used cautiously. Close monitoring of coagulation state is crucial following reversal, and use of fresh frozen plasma for reversal may require administration of large volume, which may not tolerant in older people who already have a congestive heart failure. So, these are the medications, and the warfarin we can use vitamin K, FFP, or PCC. In for heparin, protamine sulfate can be used. For a low molecular weight heparin, we can also use protamine sulfate. So, like drugs like direct thrombin inhibitors, proxbine can be used. Then antiplatelet drugs, we can use platelet transfusion or dexamethasone. These are the other reversible agents that can be used in case of bleed that is due to antiplatelets. Pelvic fracture is also very common in elderly people due to sacropenia and osteopenia. The need for blood transfusion, even in the absence of morphology, or increased risk of bleeding are higher. The need for blood transfusion is more in elderly people because they are increased risk of bleeding, and older people have a much longer hospital stay and less likely to return to independent lifestyle following discharge. So, the mainstay for reducing the mortality and morbidity in pelvic fracture is fall prevention. This is a new thing added in our 11th edition of ATLS book, that is cervical spine column and spinal cord injuries in elderly patient. Older patient have increased risk of both cervical spine column injury and cervical cord injury due to osteoporotic and chronic degenerative condition. They are more susceptible to injury from a fall. Classic mechanism include hyperextension injuries from striking the front of the head. Odontoid fractures are exceptionally common and are also associated with poor healing irrespective of treatment choice. Spine motion restriction with a cervical collar is generally recommended, but can also lead to secondary problems such as development of pressure sores, increased intracranial pressure, dysphagia, breathing difficulty, delirium, compliance issues. The presence of degenerative spinal disease in older adult further heighten their risk of fracture SCC even with a low energy fall. In particularly, one with ankylosing spondylitis have severe injury and deficiency in patient who have a traumatic injury, who suffer a traumatic injury. This is the need. If in case of ankylosing spondylitis or any kyphosis scoliosis, it's very difficult to put a collar. So, either we can apply a collar or we can use this positioners in case of kyphosis to align the C-spine if a collar can't be put properly to stabilize the C-spine. Forceful manipulating the neck to the cervical collar can also result in injury. So, patient can be positioned, the C-spine can be stabilized or positioned by using sandbags or positioners by supporting the occiput on either side of the head in case of fixed kyphosis. So, cervical stenosis and degenerative disease of cervical spine can also put spinal cord at the risk of compression injury. Central cord syndrome, in which the motor deficit of the upper extremity is greater than lower extremity, are common in elderly population, and should obtain a neural consultation to determine the need of intervention in case of cervical trauma. In elderly patient, we have to, there are special circumstances we have to take care, such as medication, some classes of antihypertensions like alpha blockers, sedative, hypnotics, and antipsychotics have increased risk of fall in this population, and anticoagulant, antiplatelet, and direct thrombin inhibitors have increased risk of bleeding. So, prompt identification of this medication and administration of reversal agents will improve the outcome of this patient. Ageism is also a new concept that is added in ATLS 11th edition. This ageism is commonly described as implained or explained bias against individual based on their age. It is first described by first director of National Institute on Aging, Dr. Neil Butler, in 1969, referring to the discrimination against old individuals triggered by unfavorable or misleading stereotypes. Younger patients are given more priorities and more resources are allotted to young individuals than older people, and in case of life making decisions and all the decisions of their own care is not discussed with the patient. That is, older adults are excluded from decisions and decision making regarding their own care due to false assumption of cognitive decline or dementia, and the reflection on these causes like already pre-existing condition and allying physical function due to advanced age may influence the treating physician's choice of diagnostic test and limit resuscitation effect due to the overstated concern of care and expected inability to restore geriatric population's functional status to pre-existing level. This reflect on this cause and how it may influence the clinician-patient interaction and treatment decision can lead to behavior modification, improved trauma care, and resource utilization. So, this is the last slide. Geriatric trauma patients are frequently under triaged. That's why they, even if with early subtle initial physiological changes and low energy mechanism can also be combined to level of probability of under triage. Early identification of injury with appropriate resuscitation give this patient the best chance of outcome. Patients with traumatic brain injury, spinal cord injury, complex fracture, multiple rib fracture, intra-abdominal trauma should be referred to higher center for definitive management, and comorbid conditions should be taken in care while treating this patient. Pre-existing health condition can significantly affect the morbidity mortality of the patient. Shock may be masked by the medication and 5 PEs. Thorough assessment and resuscitation gives the best chance for good outcome in geriatric patient. Thank you. Pavan illa sir.